He's forum today because they have got someone who is pioneer, and he is the leading steering member, one of the steering members in what they need to know. So he is a consultant neurologist and an epidemiologist at the Hinduja National Hospital, Mumbai. And he also has, or he is an active member in many, many hospitals and institutions all over the world. Few to say are, he's an honorary associate professor in neurology at the JJ Hospital, Mumbai, and he's also a visiting fellow in epilepsy at the Cleveland Clinic, USA, and a neurologist in the Ramakrishna Mission Hospital, Mumbai. So to add, like this, he goes on and on. I think he keeps himself fully busy all the time, rendering his esteemed service to all possible patients. And he's also a founder trustee of the Forum for Indian Neurology Education. So he is a leading educator also. And last but not the least, he is one of the steering committee members for the ELICIT, which is the task force of intensivist palliative physicians and neurologists to decide on what is that's needed to decide for end-of-life care for patients in India. So without much ado, I think I will hand over the platform to Dr. Roop Gursahani to take us through the important topic today. Warm welcome, sir.
Just give me a minute. Yeah, hi, I'm audible?
Yes.
Okay, so I'll just start sharing my screen. And here we go.
Yes, we can see your screen also.
Yeah, I need to just start. Yeah, there we are. Thank you, Dr. Ada, for that very generous welcome. I mean, you've given me more accolades than I have ever deserved, but anyway, thank you very much. So it's a pleasure to be back again and to be speaking on this topic at Pallium. And let me begin by telling you that I'm giving this talk not just as a doctor to doctors, but also as one citizen to others, though of course with more medical knowledge than most. So what do we intend to cover in this? So let me get the user point. We need to try and recognize the dying process from chronic disease and from cancer. We need to learn to prognosticate using various instruments and tools, identify and assess symptoms that need to be addressed, understand the bereavement process, and finally analyze the current medical legal scenario. So let me ask you, do you ever think about your own death? Or if at all you do, how do you imagine it? Most of us imagine that we will probably one day wake up in heaven listening to either Bhimsen Joshi or maybe rock or whatever, but nobody thinks of dying with pain and suffering. And there's this famous comedian who made this quip way back in 75. He said, "I'm not afraid of death. I just don't want to be there when it happens." So just to remind you of the boundaries that we usually use for serious life-limiting illnesses, we know that palliative care is applicable to all serious health-related suffering, and that it often shades into end-of-life care. The limit of end-of-life care is generally more by convention than by real logic, kept at up to 1 year. Terminal care then, of course, becomes weeks to months, and then actively dying is when you have the irreversible process, which then takes over. And these definitions, as you will see, are not really precise, but these are the best that we have. So terminal illness is a state from which recovery cannot be expected with currently available treatments, and death is considered to be unavoidable in the foreseeable future. How far is the foreseeable future? Well, in cancer, it can be weeks to months, but in my business, in neurology, in dementia, it can be up to a decade. You know that somebody is going to die of dementia or its complications, but you know that this is going to be a very long process. So we also think in terms of end of life care, where the approach to a terminally ill patient shifts the focus of care to symptom control, to comfort, to quality of life and quality of dying, with support for the family. And at this stage, treatments aimed at cure and or prolongation of life can be ethically be stopped. If you look at disease trajectories towards the end of life, we identify these four have been identified quite a while ago. The first is sudden death. The second is terminal illness, then organ failure, and then the frailty. This was a paper that looked at Medicare, the people who died on US Medicare, which takes in patients after the age of 65. And they did the survey by random sampling, captured 92% of all deaths. And so we can presume that these are fairly representative. So if you look at how we die, I said earlier that most of us imagine that for us, death will be sudden. One morning you'll wake up in heaven. But that is not the way it usually happens. Typically, before the age of 50, younger people die suddenly. They do more risky things. They become terrorists or soldiers. They smoke too much, and so on. After the age of 50 years, most risky behaviors have culled the vulnerable, and less than 10%, something like about 7% of people actually die suddenly. And as I say, you need a lot of punya, like our long-haired ex-president, to be able to die in the mid-80s, doing what he enjoyed doing. He was lecturing, and he had a heart attack and he passed away within a few minutes. So for most of us, it is going to be one of these three trajectories. Actually, there's a fourth that came up later, and I'll discuss that a little later. So the first of these is called the terminal illness trajectory. Now, if you look at cancer, typically it is diagnosed in people in their 60s. And for a good period of time, cancer patients maintain fairly normal function until there's a time, usually when the second chemotherapy has failed or the tumor burden crosses a certain point, and then their downward trajectory begins. It's called the waterfall trajectory because you can literally predict when it will reach baseline. And this, of course, refers to cancer, but it can also refer to motor neuron disease. And it represents just about 20% of all deaths. And here you can recognize our former defense minister and Goa chief minister, Manohar Parrikar, towards the end of his life. Then you have the next trajectory. This is the trajectory of organ failure. So in organ failure, these are individuals whose function has probably already declined to some extent. And as they go along the course, they keep having crises during which they may enter in hospital, improve, then come out again, but keep declining steadily. And we call this the entry, re-entry, or the looping trajectory. And this typically affects people in their 70s. So it could be bad diabetes, blood pressure, and any combination of organ failures. And this accounts for less than 20%, around about 15%. And since VIPs always get transplants, the poster boy for this is the common man. Then the third natural trajectory is termed frailty and dementia. And in this trajectory, people enter it usually in their late 70s, early 80s, as it is at a low level of function, and they keep dwindling away until finally they pass away. And this is called the trajectory of frailty and dementia, and it affects people in their 80s or 90s. It's going to affect about 50% of us, those of us who plan to lead long, healthy lives. This is how it will end. Old age, frailty, dementia, right? So if you remember, Atal Bihari Vajpayee lost his election in 2004 and passed away in 2018. And we really literally heard nothing much from him after 2004. But there is a fifth trajectory that has now been identified, and that is called the catastrophic event trajectory. And in this catastrophic event trajectory, you have an individual who's functioning at a normal level and then is hit by a truck, a bomb, a bullet, a clot, or has a heart attack and is revived. And under earlier circumstances, before the advent of critical care, would have died. Except that modern critical care rescues these patients, and then they continue on at a fairly low level. Some of them may have some amount of neurologic recovery, and this we call the vegetative state. But very often they will just hang around at that level and then finally pass away. This is from the fifth trajectory of critical illness. It's interesting to note that elderly people who are otherwise well functioning may have a systemic event, hip fracture, and have a severe post-operative course with delirium and so on, and end up here without it actually having any obvious primary neurologic involvement. So the responsibility that we have was one that was recognized long ago by Hippocrates. And that was the responsibility of prognosis. Of course, Hippocrates had a slightly different take on this. He said, in the presence of the sick, by foretelling the past, the present, the past, and the future, and explaining the omissions which patients have been guilty of, men will have confidence to entrust themselves to such a physician. Not sure if I would buy all of this, but for various reasons, prognostication is something that is pretty important. And the importance is something that we've begun to realize only now. And that is, it is actually a bioethical responsibility. You cannot have informed consent without information. So information and prognostication are a crucial part of what we do. And yet, we find it difficult. This is because we are required to prognosticate in a fashion that is simultaneously, yet we feel impossibly honest, accurate, and optimistic. And to round this triangle, we literally struggle, except those of us who have had some amount of training in communication skills. So I'd like to come back to this point, and this is something that I'm sure you'll be able to accept now, and that is that most deaths can be anticipated, although a minority are unexpected. And that if you anticipate, you can plan, you can avoid crisis admissions, and you can give care that is tailored to people's wishes so that more people live and die in the place and manner of their choice. So how do you do this? Well, we can recognize 4 triggers that suggest patients are nearing the end of life. And these are termed the surprise question, the general indicators of decline. Then there are specific clinical indicators related to various conditions and organ systems. And then the trigger is actually decisional. When physicians, patients, everyone together decides that disease-directed therapy has to be replaced by comfort care. Of course, you can also do both together, but this is a specific decision that needs to be taken. So what is a surprise question? The surprise question actually turned up quite some time ago when it was realized that you could actually intuitively be asked this question: would you be surprised if this patient were to die in the next year? And if you said no, you actually are putting together clinical comorbidities, social and other factors to get a whole picture of deterioration, which is at times you may not be able to analyze the individual elements, but your intuition tells you that. And it has been documented statistically to be about 80% accurate when experienced oncologists do this in their specialty. For non-oncology, it's around about 70%. Of course, you can use different time frames, but typically most people look at it as a 1-year time frame. Then there are general indicators of decline. And these general indicators of decline, the first and foremost is decreasing activity. So when somebody's functional performance starts going down, their self-care ability goes down, they spend more than 50% of the day in the bed or chair, their dependence in most activities of daily living is complete. Of course, you need to do this systematically. There are scales and scores that allow you to do this. For oncology, typically this is a Karnofsky performance score. Once you do this, then you can identify the point at which mortality becomes imminent. The other indicators, general indicators of decline, are comorbidity. And that's understandable. Anybody who has more than one disease, you're adding two burdens. Then obviously when disease is advanced to the point that symptoms are declining, they are unstable, and this applies to non-oncology. In Parkinson's, for instance, severe constipation to the point of obstipation is a marker. Or somebody is no longer responding to treatments. Say, for instance, diabetes remains uncontrolled, or pulmonary disease starts requiring home oxygen. There are other numbers that we can use: progressive weight loss more than 10%, or a serum albumin, which means that the liver is no longer producing enough protein, less than 2.5. Another marker is unplanned or crisis admissions. So more than 3 admissions in 6 months, again, is a marker. And then you can have what are termed sentinel events. Everything seems to be okay, and suddenly something happens out of the blue. So a serious fall and a fracture, you can see that is obvious. But sometimes it may be not clearly medical. The loss of a spouse. Those were general indicators. Let's look at disease-specific indicators. Now, these are most accurate for cancer, as you can remember from the trajectory that I showed you in the beginning. So if somebody has recurrence and/or metastasis after initial therapy, stage 4 disease, or has multimorbidities and is not amenable to further treatment, if such a patient is spending more than 50% of the time in bed or lying down, generally the prognosis is estimated to be over 3 months or less. But for organ failures, it can be fairly erratic and unpredictable. And in contrast to the simple indications that we got for oncology, look at the number of indicators that we have for heart disease, for chronic obstructive pulmonary disease, kidney disease, liver disease, and certainly so for neurology, where each disease has its own signposts of decline and worsening. So I'm not going to go into the details of this, except to point out that if anybody is interested, the goldstandardsframework.org is a free site, and you can download all this material from there. As we said earlier, the last trigger is decisional. So for somebody who has neurologic decline, especially dementia, frailty, or somebody who has multimorbidities, where physical and or cognitive function is declining, where symptoms are complex and too difficult to control, these include swallowing problems or speech problems, you can actually decide enough is enough. And that is where it can actually begin to end. Now, I'm going to stop here because obviously I've covered concepts that may be new to you and give you a few minutes to ask questions. You can put them up in the chat box, or you can unmute yourself and ask them. And then we'll go on to the next stage. Anything in the chat? So I'll be taking another couple.
Nothing so far. So
okay, I'll be taking a couple more stops in between. So I recommend that you think of questions that you have to ask, because this is much of this is going to be probably new to you, and it may be better for you to check this out here. Anything? No.
I just thought maybe I can just ask something.
Go ahead.
Which maybe,
Shoot.
what I thought was something for in their perspective, how like palliative physician and the general physician or the parent physician working together. When, if that starts, will that be beneficial to have a convenient conversation and moving forward?
So I think one of the problems is that there aren't too many palliative care physicians around. Those that are largely focused on oncology. So if you look at it, 80% of deaths are not really palliative care is often not available to them. Then there's been a lot of discussion about how and when do you involve palliative care. Say in a non-oncologic case, if by chance you do have the facilities. I think whenever suffering gets complex, whenever the symptoms are unmanageable, whenever there's conflict, it may be ethical, it may be just social, between the family, within the family, between the family and the treating team. These are all situations where experienced palliative care physicians can come in and sort it out, or at least start moving things to a more logical conclusion. So ideally, if we do have a palliative care physician, then whenever we reach the stage at which we are, there is obviously distress all around, it is time to make a referral. This will vary from organization. Yeah, go ahead.
There's one question in the chat box. So if you have finished what you were mentioning.
Yeah. Go ahead.
Okay, it says, please explain about how dementia is considered as terminal illness.
Yeah, so a terminal illness is one from which you can expect the patient to die from in a foreseeable period of time. So dementia does meet that criterion. It's a foreseeable period of time, in the sense it may be years. And people, once a diagnosis of Alzheimer's is made, if the person is otherwise reasonably healthy, then they will die of the Alzheimer's, which is why it is considered a terminal disease. Is that okay? Chalo. In fact, the next case, I'm starting with cases, and the case actually will answer this point. So let's take this one. So this is a gentleman who was 81 when he first met a neurologist, not me. Started with forgetfulness, diagnosed early dementia, mild depression. And he himself asked the neurologist, what's happening to me? but there was no meaningful discussion. And he had an active social life. He had been working till 2 years before this happened, resigned because he felt that he was not able to cope. And he and his wife lived alone. Children were settled in the US. So often that happens. And you can see how his cognitive decline played out. In 2015, he could maintain an independent daily routine, but there were occasional mishaps. And life was starting to get simplified. One habit that he had was of asking his wife the same question again and again, again and again. By 2016, he started to need supervision, especially during the bath and the toilet. And it, in fact, became a little troublesome for the wife because by 2017, behavioral issues also started to come up, and including prodding for a bath, clothes change, angry outbursts, and one episode of nighttime wandering. And I think during this time, his wife actually had an episode of ischemic heart disease and needed to be admitted when one of the children came down to take over. Anyway, in January 2018, about 4 years after diagnosis of dementia, he comes into hospital with delirium due to urinary tract infection, and turns out he has a hyperfunctioning detrusor, and he needs a suprapubic cystoscopy. Now, when he's discharged this time, he's still walking around, but now he needs supervision for all basic activities, which means somebody has to stand with him when he gets out of bed, goes to the bath, cleans himself after toilet, or helps him, or actually cleans him up, and so on. And he's now talking much less. And when the wife now asks the neurologist, "Ab kya hoga?" again, a similar answer. This is expected. Well, towards the end of this year, he comes back again to hospital, this time with hyponatremia. And when he's discharged this time, in fact, even though there was nothing that was directly that had happened to the CNS, he became completely bedbound and nearly mute. And barely a couple of months after that, he came in again with recurrent generalized seizures. He was treated appropriately, the seizures were controlled, but he did get intubated. There were no changes on the CT head, no obvious metabolic cause, so probably this was due to the dementia itself. He could be weaned off the ventilator, but for reasons that were not very clear to me, he also got a tracheostomy on day 8. And this was around the time when I was seeing this patient. And when I then suggested that they also needed to do a PEG, the family balked. And obviously, since I wasn't sure how to handle this, I called in our palliative care physician. And between the two of us, we finally managed to discharge him for home care a month after he had come. When he was discharged, he was effectively in the persistent vegetative state. And the family directly asked me, could we have involved palliative care earlier? And let me explain to you what earlier meant. So he was at home with hired caregivers and an 82-year-old wife, and our palliative care physician was helping the family physician manage. But regardless, he started to develop pressure sores, and then finally, one day he vomited, aspirated, stopped breathing, and passed away. So if you look at dementia, somebody asked, is it a terminal illness? Well, from 2014 to 2018, maybe 2014, you might say, okay, maybe yes, maybe not. But by 2015, the progress was continuous. And it's important for us to recognize when an illness becomes terminal. If the family had been informed about the roadmap ahead, the first is at diagnosis, there was still scope for what is termed advanced care planning, when a patient and family figures out how far they want to go with treatment and so on. When he came in with urinary tract infection, at least at that time, the family should have been told that this disease is now terminal. Maybe not in a few months, but at least in a few years. And by the time of the second admission, when he came in just for hyponatremia, the focus should have been on avoiding future hospitalizations. In fact, when he came in for seizures, maybe we would just have controlled the seizures and sent him back. Um, the intubation was not strictly necessary, and in a patient like this, where you have thought of a terminal issue, you actually move to enforcing DNAR orders. And instead of the tracheostomy, he could have had a palliative extubation. The last stage of his illness and suffering would definitely have been cut short by 2 to 3 months. So I'm sure some of you will wonder if this is passive euthanasia. Does anybody want to ask me that? Maybe you do. Let's see. Unless you know enough about this topic. So the second case is this gentleman who develops cancer. 76 years old, socially active, one day finds blood in the stool, gets a colonoscopy. There's a sigmoid colon carcinoma, which gets biopsied and then gets surgery. And after the left hemicolectomy, is referred to an oncologist. And he goes to see the oncologist with his daughter, and the oncologist speaks only to the daughter, which is so often true. We avoid looking at people where we know that the prognosis is bad. Anyway, he started off on chemotherapy, which he tolerated well, except one episode of confusion. What the oncologist didn't know is that thanks to the US-based grandson, palliative care got involved fairly early, just after the first chemotherapy. And after the chemo was done, he had regular follow-ups. So this was all through 2017, and a PET CT was scheduled in November 2017, and that showed extensive mets with expected survival of 4 months. So back they went to the oncologist, who offered palliative chemo with targeted therapy, which they said the best case of survival would be 24 months, but median would be about 8 to 10 months. So our gentleman said no. And he chose palliative care. There was a home visit, and hospice care was set up at home. Now see what happens next. As things go down further, there are prolonged discussions with the palliative care team, together with the family, including daughter and grandson from the US. The grandson asked for and got 2 months leave from his new job, flew to Mumbai to take care of his Nana, who was now in bed most of the time. And between them, they made sure that their wishes were actually documented. And in May 2018, he was now completely dependent. And that's when the daughter flew in. And it was literally, he waited for her to arrive, and he passed away the next day. So if you see the difference between a cancer death and a non-cancer death, in a cancer death, you have a defined trajectory, defined prognosis, admissions can be avoided. And because here there was a palliative care team involved, the patient and family retain control if there is transparency, if they know what's coming. In non-oncology, the trajectory is both prolonged and can be erratic. Recurrent admissions may be unavoidable. The problem is, especially in dementia, that there's an early loss of personhood. Our cancer patient retained control till here. He was in charge till here. When did my dementia patient lose charge? Somewhere around here. And that is why expensive and unavoidable ICU care at the very end is almost always the rule. But these are two specific diseases. What if the diagnosis is old age? Remember that not many of us are expected to last beyond 80 years. And it also depends on how well we age. So there is chronologic age, which is number of years, versus biologic age, which is your basic fitness and so on. So this is the story of a lady who in 2014, she was 80 at that time, she moved to Nasik, which is a city somewhere in the vicinity of Mumbai because they wanted to live near and be supported by her only daughter. She herself had poorly controlled diabetes on insulin, and she had had episodes of hypoglycemia and decay, and the daughter put her foot down and said, "You need to move next to me." The husband otherwise was reasonably well. She settled into a new home, uh, got an active social life, and then things started to happen. In 2016, she had a febrile diarrheal illness and needed admission. So she's 82 now. Later that year, she had a fall at home, a fracture, neck femur, which needed hip replacement, and had post-operative delirium. But at the end of it, she needed a health aid, and she was walking with a walker. So you can see one downturn. And then in 2017, so about, when she was 83, the husband collapsed after 3 days of vague chest pain and mild fever, which turned out to be lobar pneumonia and sepsis. He lapsed into multi-organ failure very rapidly, and his wife confirmed DNI and DNAR, and he passed away within 48 hours of it. Now, the reason this happened is when she had her bad spell after her fractured neck femur, both husband and wife had spoken to their daughter and made it clear that there were going to be no heroic measures. In fact, they wanted their bodies to be donated to the medical college. And between the three of them, they were very clear about what would happen. So the old lady was, she had her favorite person in the world move in to live with her. And then just about 8 months or so later, then began the third and major problem. She developed multiple superficial soft tissue abscesses. She had, if you remember, poorly controlled diabetes. Twice she got admitted, got IV antibiotics. And then in early March 2018, she had finally, we gave up and brought her home for home care with daily dressings. And when she asked, she was told that the medicines are not working. And not much more was discussed about her prognosis with her. But she actually said very clearly, I don't want to go to hospital again. And then in April 2018, the decline began. She became bedridden, needing help with all basic activities of daily living, reduced appetite, reduced intake of food and water. And in second week of June, actually lapsed into full delirium. And literally 3 days later, stopped speaking and stopped breathing. So you can see how this plays out in systemic illness, which is not really in that sense specific to any organ system. So can you predict how this will go in any individual? Well, if you look at, we spoke about prediction in oncology, in various organ failures and so on. But what about older adults with multimorbidity? Nothing, not one specific condition, maybe multiple conditions. So there are multiple bedside risk scoring systems and predictions of 1-year mortality, and I often follow this Walter index. Let's see how this works. So this gives about 1 point for male sex, 5 points for all basic activities of daily life being dependent. When you talk of basic activities of daily living, it means transferring from bed to chair or to walking, then going to the toilet, maintaining continence, cleaning oneself, taking a bath, wearing clothes, and feeding. So if you count them, they actually come out to 5 BADL that we can count. And if all of them are dependent, 5 points. Somebody whose creatinine is more than 3, 2 points. Somebody whose albumin is less than 3, Of course, the marker that we use is 2.5, but even less than 3 is considered significant, 2, and so on. Now, any individual who has more than 6 points, has a 60 to 70% risk of death in the following 1 year. Now, 65%, 65% risk of death means that 35% survive. But the 35% is subject to the same risk. And then the same risk. So you're actually identifying a cohort which is 99%, I mean, 90 something, 97, 98%, not likely to survive beyond 3 years. Do we often use this kind of markers? Do we actually inform families? No, we don't. So why is there this lacuna? Remember that before the middle of the 20th century, diagnosis, therapeutics, and prognosis were 3 equally important functions of the physician. As medical treatments improved, the skill of prognosis declined. Everywhere. You can look at it in terms of our textbooks and so on. But we also forgot that prognostication is not just foreseeing, it's also foretelling. And when you foretell, you are combining honesty, accuracy, and optimism, which is an impossible triangle, but you can do it if you use communication skills. And I always tell my students that if you do not commit to foretelling, your foresight will atrophy. Because if you can see and you don't tell, then you don't test yourself. You don't challenge yourself. And that is why it's important to combine both foreseeing and foretelling. Now, what do you foretell? So the content of communication for end-of-life care is divided into 3. The first is goals of care. So this is basically our own responsibility. We have to combine it with patient education. And they have to be explored and or elaborated with patient, family, and can be done over multiple visits. So it usually supplements the usual discussion about treatments. Sorry, do I have this? Yeah. So what do you think when you think about goals of care? Now, effectively, medicine has 3 major goals. The first is longevity. Ideally, if we could, we'd make everybody live till 1,000 years. The second is function. Nobody should become dependent. And comfort. There should be no suffering. The problem is that these 3 often cannot all be achieved. You have to decide which one to prioritize. And how do you find out what a patient or family might prioritize? Because they also have never thought about it. So you look at values, you look at wishes, you look at preferences, you look at their own sense of duty. And as you converse with them, these are markers that pop up in our conversation. And it is important for us to identify these markers and trace them further. And when you do that, then you can help patients and families make these decisions. And to sort out their goals of care, you will be thinking that these are like long conversations. No, once you're trained in this, you actually keep picking these trigger points in your normal conversation, and you can actually elaborate them. So you have to find out how much they understand, how much they want to know. You have to explain uncertainty. Probably the best way of pinning things down is to find out the patient's wishes about place of care. Where would you like to pass your last place? Home, hospital, ICU? Does the caregiver agree? And just remember that wishes and plans may change. Now, the next item of communication is termed advanced care planning. Now, advanced care planning includes living will, proxy decision maker, and so on. So it obviously starts off from goals of care, but it becomes a system for documenting this information and making it actionable. And in India, it is now legally valid, though it is not really backed by public policy. And we will discuss this towards the end. If you do these two right, then you have shared decision making, where you combine patient or family inputs with our own input about prognosis and what choices are feasible so that you can make appropriate in the moment decisions. And in advanced care planning, specific end of life decisions that we make are one is, of course, preferred place of care and or death, and life saving treatments. Now, you will think life saving treatments is CPR, invasive ventilation, and dialysis. No, it's also mode of feeding. Rice tube and percutaneous endoscope gastrostomy are both life saving treatments and can be refused. Parenteral medications other than those required for symptom control, so IV antibiotics, chemotherapy, even IV fluids, can be refused. If you do this right, it improves the patient's quality of life because they get a sense of control over their last days. It reduces burden, conflict, stress, anxiety, and depression in surviving family members. And obviously, it decreases the use of unwanted intensive medical treatment towards the end of life. The challenges are from the patient is that the fear of death and the difficulty of thinking or talking about end of life care issues. For clinicians, well, we usually quote lack of time and difficulty in discussing prognosis, but I think it's basically our lack of training in communication skills. Why then is this not done? Well, families do not see the timeline of decline. So, for instance, when I am talking about this, very often I will draw one of the trajectories, the one that is applicable to this patient, on a bit of paper, show it to the family, and then their eyes open. They say, oh, we were there, now we are here. What about clinicians? May not see it. I mean, hopefully, those of you who go through this course can't make that excuse. See it and ignore it, but more importantly, don't know how to handle it. And as I said earlier, if you don't know how to foretell, your foresight will atrophy. Communication is a learned skill, as much a learned skill as surgery or diagnostics. It requires training, it requires practice, it requires assessment and certification. And then you go into performance where you prepare for a encounter, complete the procedure, review it so that you can complete this circle. Unfortunately, when I tell my senior colleagues that they need to learn communication skills, I usually get this reaction. So I'm going to stop again and take questions again. Anything in?
There's nothing in the chat box at present. They can unmute and also ask if someone wants to ask. Please do unmute and ask also.
I'll just take 15 seconds more and then we'll go on.
Okay.
Right. So how do you know when a person is dying? Or as we term it, actively dying? This is purely a clinical judgment. So active dying is the period preceding death during which time the patient's physiological functions wane. And we have to prepare the family and caregivers. The care has to be multidisciplinary and holistic. Multidisciplinary doesn't mean that you have to have a whole big team. You have to be capable yourself of addressing the various facets of this process. And again, these are not very complex. Once your attitudes are set, the knowledge will fall into place. And so will the practice. And we also include after death care and bereavement support. Now, at the end of life, months to weeks before death, months to weeks, we have pre-active dying, which consists of physical and psychosocial withdrawal. So think of the second patient, the one with cancer, or the third patient. When the old lady, when she came back from hospital, when it was obvious that the infection would not get controlled. So this has decreased ambulation, withdrawal, decreasing oral intake, occasional incontinence, and weight loss. Right? So this is physical and psychosocial withdrawal. Then comes the beginning of active dying. And in the initial part of it, weeks to days before death, the marker is the appearance of neurologic involvement, delirium. We call this terminal delirium. This can be episodic, but could also be continuous. Blood pressure drops, pulse becomes irregular, more and more drowsy, intake decreases, completely confined to bed, and so on. And then you come to the stage of imminent death, which is days to hours before death, when frankly, nothing will any longer work. And this is when vital signs begin to deteriorate. So consciousness, breathing, inability to swallow secretions, hemodynamic changes, yellow sallow appearance of face. And for me, one particular marker, and that is the appearance of gasping. Now, gasping is pretty interesting. All of us recognize it when we see it, but we don't know why it occurs. The closest understanding that people have is from records of people who arrested, means had cardiac arrest and were revived. And it's believed that gasping represents brainstem hypoxia. And typically, when somebody shows this gasping movement, we think death is imminent. So our goals in caring for the dying are basically to ensure the patient's comfort, make the end of life peaceful and dignified, make the memory of the dying process as positive as possible, and review drug charts. If you need medications in the future, you may need to do what is called anticipatory prescribing and start to manage refractory symptoms. The challenges include maintaining nutrition and hydration. At this stage, there's low appetite, aversion to food, stomatitis, pharyngitis, inability, so many things. And it is important for us to clarify to the family that feeding tubes do not enhance survival or quality of life at the end of life. If you put in a rice tube, the patient is very likely to get agitated as they try to pull it out. So you have to restrain them, and then pressure ulcers worsen. And feeding tubes do not reduce the risk of aspiration or pneumonia, because much aspiration is due to regurgitation. So these decisions about artificial hydration have to be made with the patient's best interests and quality of life. But if, say, a tube is already in place, then you review the rate of volume according to individual needs so that you avoid overhydration. And ideally, you should avoid parenteral nutrition. The recommendations are that you provide food items which the patient likes and feed them by hand. Thirst can be managed with good mouth care and ice pieces, small ice pieces in the mouth, or by moistening and lubricating the lips. Some things that we need to understand, because it's only then we can communicate it to the family, is that the body is shutting down and intake is going down accordingly, not the other way around. It's not that because intake is going down, that is why the body is shut. Total fluid requirement is about 1 liter per day, which need be you can give it subcutaneously. You have to confirm about 1 liter means about urine 3 to 4 times per day. No rice tube, no IV fluids, and ideally it's hand feeding or with spoon. And with this, the aspiration risk is actually quite manageable. Then you review medications. Stop all medicines that are not required for symptom control. If there are some medicines that you think are important or are required for symptom control, you can give them subcutaneously. Which are the medications that you would need to review? Intravenous antibiotics can stop. Though people may argue about that. Aspirin, statins, vitamin supplements, what on earth do you need to give a medicine which is meant for survival into the next decade? Then comes the question of oral hypoglycemic medications and insulin. Typically, oral hypoglycemics can stop because there's no intake. And even insulin tends to dwindle. And in fact, if the sugar is not crossing 200 or so, I would just stop the insulin. And other stuff like antidepressants obviously needs to stop. Now, the symptoms that bother the patient and the family, the first and foremost is pain. Then there's agitation, incontinence, dyspnea, and we'll cover, and nausea and vomiting, and cover the first four. To treat them, you need to have a route of delivery of medications. Obviously, an IV line is difficult to maintain. People can use transdermal and rectal, but probably the commonest site that is used in palliative care is the subcutaneous site with a scalp pen that is placed in a convenient location, and you can give a slow drip. You can give up to 1 liter per day to the subcutaneous route. Okay, so pain has to be clearly assessed and addressed. If the patient is not able to speak, there are validated scales like pain AD, which is used for pain in somebody who has dementia and is mute. And you need to have access to opioids, a reliable route to administer it, and sometimes you may need to titrate rapidly in case there is severe pain. What if somebody is restless or agitated? First of all, look for these three: retention, constipation, pain. And very often, pain is being treated with suboptimal opioids, and then people blame the opioids. No. Review medication. Various drugs have anticholinergic properties, and you can check these out. If somebody is getting polypharmacy, then these need to come off. You improve their natural stimulation with glasses, natural light, remove irritants, stop stimulating noise, put familiar objects and people in the room, and ideally protect the patient's sleep with no interventions at night. If you're speaking to the patient, engage, but don't shout at them. But if nothing works, then haloperidol is the treatment of choice, except when it is a neurological condition with Parkinsonian features, because haloperidol can rapidly worsen the Parkinsonism. Benzodiazepines are not recommended. They can be activating and they can worsen delirium, should be used with caution, never the first choice. Okay, coming on to breathlessness. There are 4 principles. You correct the correctable, you provide air movement on the face, you reduce the perception of dyspnea, and if it is intolerable, you go to palliative sedation. So pleurocentesis, diuretics are easy to understand. The fan on the face is also interesting, but it works. And the most important is to use morphine. Generally, before the last few days, the doses are pretty small, but towards the end, they can rise steeply. Nausea and vomiting, again, reverse the reversible. And here you have constipation, hypokalemia, and hypocalcemia. The first line drugs include include metoclopramide and even haloperidol. Ondansetron, we all know, but it's little milder than, and you might need to use one of the stronger drugs. Adjuvant drugs and second line drugs are also used. And these can be given subcutaneously, but some of them are available in sublingual and intranasal space. Right. One symptom that really is not an issue for the patient, but is an issue for the family is the death rattle because of pooled secretions. And once this appears, it's a predictor of death. Well, 50% in 24 hours and 76% within 72 hours. The first is pharyngeal, because swallowing reflexes are inhibited. The second is bronchial, because secretions cannot be cuffed up. And the family has to be educated that this is not causing any distress to the patient. Management is preferably non-pharmacological. You avoid suctioning because it is uncomfortable, and remove the secretion by hand. Pharmacologically, you can dry it up with glycopyrrolate and hyoscine butyl bromide. Glycopyrrolate is regularly available everywhere. For the nurses, uh, interventions that matter are mouth care, pressure sore prevention, uh, police catheterization, and monitoring for constipation. And then you prepare for the end. Now, most patients will pass away like the patients I spoke about, in bed, at home, and they fade out. But there are two dramatic events towards right at the end, which we need to be prepared for because these can be extremely distressing to the family. Um, so the first is fits or epileptic seizures. And this can happen in all neuro cases and even other illnesses. The first point is that you do not allow them to put anything into the mouth. If you know anybody who sees a fit, the first aid that um, old wives teach is to push a spoon into the mouth. Don't do it. You can break the teeth. No oral medication. You have to use subcutaneous midazolam or appropriate anti-epileptic drugs. And basically, you sedate the patient. Of course, this is if it is clearly the end of life, and the patient will gradually become unconscious, quiet, and will stop moving. In some circumstances, especially when the end of life is not otherwise clear, you might want to use other medications. But typically, if this has been discussed in advance, they will not be moved to the ICU. The second is what is called the blowout hemorrhage. This occurs with oral malignancy because of infiltration of neck arteries. And this can be even more dramatic because you see a gush of red blood. This obviously is very difficult to take. So if this is discussed in advance with caregivers, if anybody from the palliative care team is around, it's important for them to stay on site until the story is over. So you use dark towels, preferably green, because red doesn't show up on that, and apply steady pressure and sedate the patient quickly with midazolam or whatever you have on hand. And this obviously also will end pretty fast. What if the symptoms are refractory? Breathlessness is refractory, pain is refractory, the patient's delirium is difficult, they have to be restrained to the point that they are getting damaged. So you have this option of what is termed palliative sedation. In palliative sedation, you use sedation with the intent to provide sleep and comfort. You are not affecting the natural process and you are not aiming at death. But death may be hastened because this is called the double effect. Your intent is to give comfort, but you could also hasten death at the same time. This is the way this is opposed to euthanasia, where euthanasia uses disproportionate sedatives to terminate life. And the intent is termination. The natural process is overtaken, and the sanctity of life is not really looked at because death is actively accelerated. So throughout all of this, our responsibility is not just the patient, it's also the family, because the family may be suffering as much and maybe even more. And you have to address multiple social, spiritual, religious needs. When the end comes, it may be your responsibility to confirm death. So you have to introduce yourself if you are not there when it happened. The family may or may not be there with you. Wash your hands, confirm identity, watch for signs of life, especially breaths. Check for response, voice, pain, pupils, feel for pulse. And then eventually, obviously, once you've confirmed this, exit. And of course, complete documentation. Right. So after that, the bereavement visit is required, especially in palliative care units, to collect back unused opioids. The family needs support, and they have to be explained that grief will last up to 6 months, and you have to explain the wave character. Of course, some patients will have complicated grief, and we'll talk about this. Now, throughout all of this, what really helps is anticipatory guidance. If you explain what is happening, what is likely to happen, you prepare them. You have to be available to answer questions. And there will be specific concerns that may need to be addressed. Ideally, you should be using help from within the community. If you look at bereavement, bereavement is a period during which mourning and grief occurs. So grief is the natural distress. Mourning is the outward expression of that distress. And remember that a person with a serious illness and their family will have had many losses during their illness. Everyone experiences grief uniquely based on factors such as culture, religion, nature of loss, and relationship to the deceased. So there are some cultures where the grief display is extremely prominent, and somewhere the other way around. People who are very close, especially sudden deaths, these are the most difficult to handle. In fact, grief begins well before the death and is then termed anticipatory grief. We also recognize acute, integrated, and complicated grief. Acute grief is the normal kind of grief. There's an experience of intense separation, distress, and emotional pain, and that evolves to adapting to life without the deceased, and typically declines over a period of several months. We take a period of 6 months as normal, and you have to explain to the family during this period is that grief will come in waves, and that it may seem like as though the grief is overwhelming. You have to let it pass, and it will pass. Eventually, this grief gets assimilated into a bereaved person's daily life and outlook because the consequences of the loss have now been accepted. And it is only when grief persists for an extended period of time and exceeds the expected social or cultural norms, then we call it complicated grief. And various people have defined various minimum duration. Typically, we take it as 6 months. Our responsibility is bereavement support. So the palliative care team should be available. You have to identify people who are at risk of complicated grief, and then you have to manage support and grief counseling. And typically, our responsibility ends at the end of a year when we connect again with the family to find out how they're doing. So this is as far as the medical part of it is concerned. The next segment is to do with the medical legal aspects, and I'm sure that also much of it may be new to you. I'm sure you understood that terminal illness can be identified, that the focus has to shift to symptom control and comfort, that you can and must recognize the active dying phase and prepare the family, and that you have to support the family before that and even after that. Again, a short break of about 30 seconds or so, and questions in the chat box or unmute and ask, whatever. Right, no questions so far? Okay.
No, nothing in the chat box till now.
So let's move on. Right. Now, I'm sure as experienced doctors, you have realized that as a whole, the medical profession just shies away from all these issues. And if you ask even our relatives, friends, about what they think of other doctors when they behave like this, when they kind of avoid all this, they actually see perverse incentives. They say, I mean, That's a corporate hospital. The longer they keep, the more they can visits they can sign, the more they can earn. So one of my friends actually made a joke out of it. He said a corporate hospital is one which the poor cannot enter and the rich cannot leave. But that is actually not true. If you look at it carefully, you realize that after about 3 to 5 days of intensive care, most expensive interventions, investigations are over. And hospitals don't really earn much after that. So it's not in the hospital's interest also to keep patients forever. Doctors also feel that there's a lack of legal clarity. There are no clear regulatory requirements. There's no law that says thou shalt not, on pain of. On the flip side, there's a fear of criminal charges and litigation. And we perennially hear this, and I'll show you that that is completely wrong. We definitely lack clear guidelines for prognosis outside cancer. But I believe that the most important thing that we lack is capacity. We are not trained in skills, in palliative care, end of life care, or communication skills, and we just don't know how to handle this. So, which is where we get stuck. Now, how do societies normally handle complex issues? So we have the first level is ethics, and something that you may hear repeatedly, even from our Supreme Court, and that's called constitutional morality. So liberty, fraternity, justice, equality, these are parts of constitutional morality. On the other side are the way we practice, and provided people have thought about how we practice and put it into guidelines which have evidence, these turn into policies within our practice. And between them, at some level, these get hardened. Ideally, they are laws, but they can also be judgments by the courts. If they are laws, then laws will have penalties for not performing something. Judgments can only say what is possible. They cannot add punishments. So remember that when you look at what I'm telling you next. Remember that from the 1950s onwards, as medical progress began to speed up, survival became ubiquitous. You could get admitted to the ICU and actually come out alive. And so it became more and more common to die in ICUs and in hospital, and we call this the medicalization of death. But simultaneously, human equality was rising, medical paternalism was ending, informed consent was already considered standard, patient autonomy became more and more prominent, and the living wills that we talk about nowadays were actually first discussed and spoken about in the human rights fora. And in the US, where these started, it became the world's laboratory because different states almost ran, it became like a political competition, which state has the most advanced documents. On the other side, the United Kingdom was the home of palliative care. So you can see these two, living wills, advanced medical directives, advanced care planning in America, and palliative care in the UK. And they originated simultaneously, parallelly, and for a long period of time actually did not overlap. Remember that our ethics, we always remember autonomy, beneficence, non-maleficence, and justice. But dignity and honesty are also important. So are empathy, so are compassion, fidelity, integrity. How do you use these in clinical practice? Again, I'm not going to details of this, but there is a very nice paper and an article on how to combine these and use them in clinical practice. For us, our legal framework starts off with the Constitution of India. India is a common law country, which means that principles that are elaborated by judges in judgments can become part of common law. And the only actual act that we have on end of life is the Transplantation of Human Organs and Tissues Act, which deals with brain death. Of course, there are Supreme Court judgments. Remember that there are professional guidelines. And of course, there are these other acts. Please remember that professional guidelines are what the courts will depend on when they have a doubt. I have been involved in this issue since 2011 because I was part of the medical team that looked at the Aruna Shanbag case. And eventually in 2015, three national medical associations came together to form something that you may have heard of earlier is the End of Life Care in India Task Force, ELICIT. Now, as early as the Aruna Shanbag judgment in 2011, effectively, this whole process got decriminalized. Okay. It meant that no family member could go and file an FIR on you if you withdrew futile life-sustaining treatment. Of course, there was terminology which we don't really accept and in this judgment, and it gave a fairly impractical solution. But nevertheless, as far as I was concerned, this was the most important outcome. In 2014, the Indian Association of Palliative Care and the Indian Society of Critical Care Medicine came together to formulate these guidelines for end-of-life care, producing an integrated care plan. And I strongly recommend that you read this. It's available free on the net. You can get it, you can download it. And then in 2018, was what we term the common cause judgment. And the common cause judgment actually finally put into words something that we knew all along, but had never been put down in Indian jurisprudence. All adults with the capacity to consent have the right of self-determination and autonomy. A competent person who has come of age has the right to refuse specific treatment or all treatment or opt for an alternative treatment, even if such decision entails a risk of death. You can treat people in emergency only when it is not practical to obtain the patient's consent and his or her life is in danger. But where a patient has already made a valid advance directive, which is free from reasonable doubt, and specifying that he or she does not wish to be treated, then such directive has to be given effect to. And this is the law of the land. But as I said earlier, this is a judgment. It doesn't say what happens if you don't, if you still go ahead and intubate this patient. That I'm sure is some amount of interesting judgments that we are waiting for. But unless you want to be the subject of one of those, I suggest you follow this. Right. So between 2018 and 2020, till the start of the pandemic, the group that I am part of, and we'd been part of multiple documents. Blue Maple is the end-of-life care document that Kasturba Hospital, Manipal uses. Then we formulated Living Will Advanced Medical Directive form, which is available on the website of Pallium India, and I suggest you download this. Then I was part of the group that wrote up the DNAR ICMR consensus guidelines. And then AIMS Delhi put out a fairly systematic, somewhat similar to Blue Maple, end-of-life care guidelines for applicable for AIMS Delhi, but obviously usable for all their hospitals. And since AIMS is a statutory body, I recommend that you take these. Of course, things have evolved a little further and we are yet to update all this completely, but this is as watertight as you can get. And for private hospitals, there was a FICCI-led initiative to provide a document. In January 24, 2023, the Supreme Court actually made this possible to be implemented. This was because in the judgment of 2018, they had prescribed a difficult pathway, which required the collector to be involved. And effectively, nobody ever used that pathway. uh, uh, and documents that we made actually focused on withholding rather than withdrawing care. So in 2000 and, in January, on January 24, 2023, finally the Supreme Court made all this process much easier. Remember that this is all about patient self-determination and autonomy. How did they make it easier? Sorry, I need to go back and clarify. Do I have a slide on this? Yeah. So, right. So what they did is they made the living will executable without, earlier it needed to be signed by the judicial magistrate first class, and most of us found that the judicial magistrate first class was least interested in doing this. Now all that you need to do is have it attested by a notary. And the second is that the withdrawal no longer needs to involve the district collector and the judicial magistrate and so on. It's become much simpler, and I explained that. Remember that all of this is about patient self-determination and autonomy. No country has comprehensive end-of-life care legislation. As far as we are concerned, these judgments are the law of the land. And remember that autonomy is not possible without adequate information and communication. Again, I've shown you this. Yeah. Now, what many people think is that taking a decision of withdrawal may open them up to some kind of court cases and so on. Is that so? Well, we are yet to find out how this will play out in India, but in the US, most of the litigation is in the other direction. People are filing suit for wrongful life when they have already made decisions to not have resuscitation, and doctors go ahead and do that. Well, the courts are likely to punish hospitals and doctors for that. In India, poor end-of-life care is one of the major causes of the systemic distrust of the medical profession in India, and we really now have no excuses for not addressing and fixing this issue. So how do we address this issue as of now? So the due process for withdrawing life-sustaining treatment should ideally be backed by documented hospital policy. The first is you accurately identify terminal illness and the prognosis. See that there's a consensus amongst all healthcare providers. And once you have done this, you need to have a minimum of 3 consultants. That's called the first end-of-life committee. That would include, obviously, the primary physician agreeing on this. Then, obviously, if the patient is competent, the patient needs to be informed and at least asked if they want to know what is happening. If the patient is incompetent, but has an advanced medical directive available, then you work with the appointed proxy to make decisions. If there is no advanced medical directive, then you have to identify an appropriate surrogate. A surrogate could be the wife, the children, brothers, parents, and you have to use a hierarchy. You cannot say call the youngest son and ignore older children and the spouse. So this surrogate hierarchy is elaborated in the AIMS end-of-life care document, and you can look that up. Once you have done that, you confirm the hierarchy, confirm the consensus, and if there is consensus between both sides, the treating side and the patient family side, then you complete documentation with a detailed note to be signed out by appropriate surrogates and the 3 consultants. At this stage, this is what happens with the new Supreme Court ruling, that this needs to be reviewed by a standing body. This is called the second end-of-life care committee. These are 3 doctors who could be from the same hospital, but could be from elsewhere as well. The head, the chair of that committee has to be nominated from the government side, and they have to give their decision within 48 hours. And if all of this goes through without any conflict, then you go ahead with withdrawal. So for us as citizens, I'm coming back to that point. It is our responsibility to make sure that these discussions, these decisions should not be left till the very end. You have to begin by speaking to those close to you. You have to choose your surrogates or healthcare proxies, confirm that they accept the responsibility, understand your wishes, and will follow them. You also have to decide whether they have any discretion or not. And when you make an advance medical directive, it has to be signed in front of two witnesses and attested by a notary. This is the document that you will see on the Pallium India website, and you can download it. And this has various components. It's available on other websites also, including the Indian Association of Palliative Care. If you ever do make one, remember that you must show it to every doctor you consult so that you will find out if the doctor is willing to accept it, will be able to tell you the hospital's policy so that you know where to get admitted. And more importantly, your own doctor will know your wishes. What if this is not done? Remember that we now have the means to keep the body alive indefinitely should we choose to do so. Barbara and George Bush, the senior Bush, passed away in their own beds. Children, pets, friends, everybody around their beds, and they're smiling. Our poor Atal Bihari died on extracorporeal membrane oxygenation in the AIMS ICU after, I think, about 10 to 15 days. Lata Mangeshkar, those incomparable vocal cords were raped not once but twice. The second intubation was completely pointless. So my rule is that if you are an Indian VIP, you are condemned to torture before death. So I'm sure you all got these take-home messages, and remember that there's a predictable trajectory. Empathic communication is important. Anticipatory guidance is important. Symptom management allows patients a dignified dying process, and bereavement, carefully managed, facilitates the entry of the family back to their lives. I'm going to stop at this point, exactly at 6:30, and I'm presuming that there will still be no more questions, so we can end.
Oh, there is one question there, sir. For
Go ahead.
unused opioids, how we collect it from patient's home?
Palliative care team, please answer.
So basically, there are, I don't mind answering. So the thing is, the thing is that very many things are there. Like you have to tell them whenever you dispense opioids, you have to tell them important. It has to be kept very carefully. It cannot be disposed here, there, everywhere. So we tell them, as you saw, palliative care doesn't finish until and after bereavement care. So we give them few options. Either to bring them back to us, or when we go, we pick it up. So both are done. I have done both. See, when I worked in Adyar Cancer Institute, we used to tell them, because their home care team was less. So when we give them, and see, we are seeing them, and someone will be coming and telling that they are not well and things like that. And we used to have regular phone, we used to have a phone available. Patients could ring us, and one of us, even though we see patients, will be willing to take up the phone call also. So we will give instructions, use it. If some patient dies, keep them safely, bring it back to us as soon as possible. Next, Trivandrum team, what I've done, there also what we do, sometimes we ask them to bring, or when we go, their home visits happens, like 7 teams go out every day. So then when we go, I've picked up the tablets which were remaining from the carers who give it back to us. So that is the best way forward. We have to instruct them. See, many times this is more of teaching and explaining to them and getting it back. Did that answer your question? Yes. The thing is that main thing, you have done such a An excellent. One thing, why no questions? Everything you have answered. So that is one way of taking it.
Yeah,
Because
but
it's a, I would say, a sensitive thing, but we have to have like, I can tell it as being brave also. We have to brave to say what is possible. And one thing I always say, not that, see, if something can be done, I will put 200% effort and do it for the patient. Just because I'm in palliative care, that doesn't mean, see, I'm basically an anesthetist and intensivist. I've worked in intensive care for 25 plus years. So both sides have been, so not that I'm giving up. I'm doing the best for the patient. Even then I did the best for the patient. Even now I'm doing the best for the patient. First thing is for us to understand and know the limits and still provide care. Rather, cure is not the only thing. That's what we say. It's not that, so some little bit of brave event and things also, and communication is something I think is maybe not taught as a part of, nowadays it's becoming part of curriculum, and especially palliative care courses have an extensive 2-session on communication, which brings everyone to a very good situation where they can manage. So sir has dealt with in such great detail, and all your examples, see, I would say everyone will have 2 or 3 in their own family. You brought them up, not that even though they are quiet, no one can say, put their hand on their heart and say they've not had anyone. I normally say in my family, my brother, I say he has at least 8 or 10, 70 plus around him asking him something or the other. So I'm a general, common, middle class family person. Okay, the same only everyone. So everyone, all cases, what you've said, they will have kith and kin, friends, relatives, someone with all those. Nothing, they are not, nothing from the air.
Yes, absolutely.
So anything else anybody wants to ask? Something else? Is there a couple of messages are on the chat box with me? Someone has said all questions answered. That's why they didn't ask.
Okay.
Somebody has typed it. It's Dr. Harsha.
Yeah, okay. Thank you. Right. So we are at 6:30. I think we stop.
They've said that the lecture has highlighted so many crucial points also. So that is what is the eye-opening message. That's all. Very, very extensive. And all these documentation. And one thing, no, just last thing I see, you said, see, when someone says that they don't want intubation and things like that, but in spite of that, if it happens, where does that family stand and what happens? Just if you could, because something like that I've heard. So I just wanted to clarify that, sir. That's all.
Okay, so very clearly, the family has the right to say no. And that you cannot deny. Any hospital that says, no, this is against the law. That's why I said this is for citizens. We all have to be aware of our rights at the end of life. I skipped over a slide which spoke about the rights of the dying. But the right to be treated with dignity and to have your wishes respected is paramount.
Exactly.
And no doctor, no hospital system can say no. So unfortunately, until, for instance, in Taiwan, they actually have a law which specifies a fine for a doctor who disregards. So there is already that. It's happening across the world. In the US, there are no punishments, but there are millions of dollars of damages that are claimed. So people are understanding that this is, in India again, it will probably follow the same path. Till then, I think all of us should accept that rather than be forced by law to do what is ethically necessary, we should learn and do it ourselves voluntarily.
The sixth sense, use the sixth sense. And generally used to say when I used to work in ICU, when your top story is good, better do things and keep ahead.
Absolutely.
And the phrase what you said, I didn't catch. The corporate hospitals, the rich, the poor cannot enter, and the rich. That second, I didn't hear properly.
Yeah, so
if you don't
it
mind,
is
can you repeat?
the poor cannot enter and the rich cannot leave.
Leave. I thought leave, but I just didn't catch it. See, no,
So
because you said even though 5-day, maybe this is out of context or whatever it is, 5-day is the care, but every day in ICU costs 70,000 to 1 lakh. I have had this personal experience. So that also counts. Few lakhs, no, it could be of so much use to a child who needs to study. So many things are also there. That's why as we teach and say total pain, total family care also has to be taken in mind. And again, as the main 4 pillars of the ethics, we will not do no harm to patient. And at the same time, deliver the best to the patient too, and the family. It's a whole system. It's not just one person.
Absolutely. So I always say that when we hand back a dead body and debts, a dead body with debts, that is unforgivable.
Exactly. A big thank you, sir. So well taken through, and you have not missed anything. So
really? Thank you so much.
It's really, this is what is needed, because all queries, like even intensive care, what is happening, many things, no? If they have all this in mind, you've got all yardsticks and things, measures to find out. Go step by step. You cannot falter.
Okay, one question Dr. Harsha Bhutra has asked, should it be written or should it be verbal? The patient's wishes. So typically, how this goes is that very often, obviously, at this stage, there is no written documentation. So I would ask the family if the patient had ever talked about this, discussed it, and expressed any wishes. And very often they'll say that, oh, of course, she never wanted to be dependent. Or, oh, of course, she was very sure that she did not want to end in the ICU. Then I say, you've got your indication. And then obviously, when this is verbal, then the documentation has to be through the family. If you remember in the slide that I showed you, it has a hierarchy. A conscious patient is number 1. A written advance medical directive is number 2. And the third is the surrogate. So ideally, if you have the conscious patient saying it, then there is no way that you can deny it. But if not, then a properly written advance directive is meant to safeguard the physician who follows it in good faith. That's what it is meant to do. Okay. Yeah. Okay. So that's done.
Good. As long as it's clarified. Clear documentation. As professionals, whatever you do, and anything in doubt, have 2, like even many times, you have 2 consultants or 2 physicians sign anything like this. Date, time, to whom you spoke, who was the next of kin. All that if you document, so you have conveyed everything. Whatever rises afterwards, your black and white will only save you. Your everything, yes, you have to be careful, do everything, but you all need to know to save yourselves also.
Absolutely. Right. Let's end.
Yes. Sure. Thank you very, very much. I will hand it over to Sri Priya then.
Thank you, Dr. Roop. I believe that you might have had a very busy day, and still you always find out time to discuss about something which, many people are still reluctant to begin talking about, the end of life care. So
thank you, Sylvia.
You always walk us through the sessions with such a beauty that at least people get that fear out. That reach out. Thank you so much, and we do hope to have more and more sessions with you in future. Thank you everyone for joining us and for giving such wonderful comments to Dr. Roop, which of course I believe have motivated him a lot today. So
thank you.
reminding that this is the last one session, and the next would be the last session of our program. This is Sri Priya, along with Dr. Roop Gursahani and Dr. Radha Venkateshan, signing off from the Tips Eco Hub. See you in the next session. Till then, everyone, take care. Bye-bye.
Thank you.